I have a question about the collection of the swab. You said it's not usually required, but if you could talk more about what the criteria is when to collect a swab. And also I've read that you're going to find 5 or 6 colonized organisms. So how do you get rid of the exudate? Do you clean it first and then swab deeper? Just more about that process.
Sure. When we're collecting a wound swab, we should clean the wound and obtain that swab using the Levine technique. So the wound should be clean and the swab should be obtained from somewhere deep in the wound. We don't want the swab, to be the wound exudate. And I hear what you're saying about wounds because we know all wounds are colonized. There's bacteria in all wounds, so every wound that you swab is going to show that it has some kind of bacteria. And that's not what we need to know. We need to know are the bacteria that are in that wound stable, and is the wound still progressing, or is the bacterial burden so high that the wound is deteriorating and that person's body doesn't have the ability to fight off the infection and contain that load of bacteria. So, we're hoping that we're not going to have swabs taken and antibiotics necessarily initiated based on swab results, but antibiotics need to be considered based on the clinical signs and symptoms of the wound. So I think it's very difficult to order antibiotics, and I'm sure you're right, Dr. Laupscher. If you don't see the wound, how do you know, is it really is it just a superficial infection, or is it more local, and how aggressive do you need to be? So the swab really can be used to confirm that you've got the person on the wrong antibiotics, but it shouldn't be what solely determines whether or not that person is put on antibiotics. And I just want to talk to something you said earlier, and you were saying, you have the patient with the wound and they go to home care and then you don't see the wound again. And I hear that often because I know the home care client will present to the physician's office and the physician will look at the leg and, it's all bandaged up in compression or some fancy bandage, and the home care nurse hasn't sent supplies along for that wound to be rebandaged. So I think the physicians have difficulty saying, oh, I'm just going to cut it all off, take it all down, and look at it when they're not certain that that person will have that bandage reapplied, or that it might be days before that happens. So I think as nurses in the community, we could probably do a better job of expecting that the physician might want to see that wound, particularly if we're suspecting that it's not progressing in the direction we want, and that we should plan to redress that wound or send adequate supplies along to the doctor's office, because most doctor's offices don't have the advanced wound care products we use, and physicians and even some of the nurses in the doctor's office may not be familiar with those products. So not only would you have to package up the supplies, you would probably have to send along step-by-step directions to do it. But an alternative thing would be to send a temporary bandage and make plans to see that patient again. So is that something that
Definitely.
You would like to see?
Yeah, and I've actually been approached by physicians once I kind of let them know at a medical meeting several months ago that this nursing course was going to take place. They asked if they could enroll. There are physicians who feel helpless because we don't know what all the supplies are. And my message is, you don't worry about that, but know how to communicate with your nursing staff. Part of the pathway is, I just want to say, a standardized antibiotic protocol that the vascular surgeons, infectious diseases specialists here, and myself have kind of worked on. And so that will be part of the educational tools that are rolled out to physicians and NPs, giving the clinical kind of description of the wound when appropriate antibiotics are expected. So while the nurses have, with the order form, the initial referral form, part of the order is the nurse may do a wound swab if indicated. Certainly the expectation is that the physicians or NPs would start antibiotics independent of a swab if it's indicated, yeah.
And
So-
Oh, sorry, go ahead.
So we don't want the nurse just taking a swab and having it sent to the office. We actually want, if it warrants a swab, it actually warrants further assessment, unless that's not possible because of distance or transportation issues or availability.
Yeah, and certainly it would be nice because when the nurses do a swab, they'll be putting it in the physician or NP's name. So it's really nice if I get the result and I kind of know the background information. So you know that will generate a fax saying, done a swab, patient X coming to see you in 2 days, something like that.
And on page 4 of the assessment form, that's why we included the signs and symptoms of infection for both the diabetic foot ulcers and venous ulcers, to help that nurse recognize that it is in fact an infection. And with regards to the venous ulceration, then it's the differentiation between something that's just stalled and has a bioburden in the wound, or whether it is actually a clinical infection. Okay, so that's there for that reason.
One other little trick about the wound is if you see the redness or the weepiness, of course that's telling you another story. But there are many indolent wounds that have been discussed that aren't going to heal. And as you're aware, if you just do a local swab, you're absolutely right, it's colonized. One little trick that one can think about in terms of any referral, or either back to the primary care physician or onto a specialist, is that if you probe the wound and you're touching bone or a joint, then that has a 70% chance of probably having osteomyelitis, which requires either long-term antibiotics in multiple delivery systems. The ordering of things such as nuclear scans or MRIs actually has a low yield. The number one yield to determine if you have an osteomyelitis, and if you have a bone infection, that's different than a soft tissue infection. That can be an ulcer that looks just not fine, it's just not healing. And when you're following your wounds that Michelle was saying, and things aren't quite settling down, is there an underlying osteomyelitis? Because many times there's not very much redness, it just doesn't heal. And the gold standard for determining osteomyelitis is actually a bone biopsy, which you cannot do in your office or as a home care nurse. But the 70% take rule is that if you happen to use your hemostat and I've just touched bone, that's another sort of thinking that there's something more going on here that may not result in this healing unless we do something differently. This is beyond the soft tissue area of concerns of redness and swelling and weeping. That is a bit different.
Thanks for bringing that up, Dr. Ulmer. Is there any more questions from the audience? No? Well, I have quite a few text questions, so I'm going to start with something regarding compression bandaging. So the question is, can we initiate compression therapy after completing the lower extremity wound pathway without a physician's order? Who would like to take that question?
I think well, I'll try and answer that. I think I already did earlier when I said the primary care physician fills out that referral form, and on the bottom of the form there's 3 check boxes, and one of them is that we're referring that individual to the regional home care, and that the nurse may go ahead and treat based on standardized protocols. So yes, you can without the order, providing that everything else, is in check.
Okay.
And I can maybe just say, this is an important thing because I know often there's a considerable time lag because a fax gets sent to the physician's not in the office every day or clinic, and there's valuable time lost. So that's one of the things. If you're reusing the standardized protocols, you go ahead and compress.
Yeah, after you've done your lower leg and limb assessment and are sure that the ABS, let's say we're talking about compression, that they are fine, then for sure proceed as protocol.
So treatment is initiated right away.
Yeah.
Sooner rather than later. Okay, another question. We've been told that clients cannot be sent to Sask Abilities for pressure offloading boots unless sent by a vascular or ortho surgeon. Is it possible that family docs could send referrals so that clients can start offloading while waiting for specialist referrals? There's a delay in that too.
This is a huge problem, and this is part of what we're trying to address, is because right now, as a family physician, I can refer someone, it's just their footwear or offloading device isn't covered because it has to be referred by a specialist. So we're trying to change that. It's not going to happen right away. Yeah.
Hopefully it won't be too long, because if we look, when we look at the pathway, the goal is that everyone with a diabetic foot ulcer be referred to the vascular surgeon with the hopes that they'll be seen within 3 weeks. So if that really happens, it would be no longer than 3 weeks before we would see a diabetic get some sort of offloading, because as soon as they come into the ambulatory care clinic, if we don't have the orthotist from SAIL there, we'll just, the surgeon will fill out the referral and we'll send them from ambulatory care directly to Saskabilities. So, 3 weeks isn't great, but it's better than, there's been people who've waited months and years because nobody's actually recognized that pressure offloading was, the most important aspect of managing a diabetic foot ulcer. So,
good. Dr. Ulmer,
And
do you have
I'll
something to
that.
add?
A lot of this is historical. To be quite honest, vascular surgeons couldn't sign a form for offloading unless an orthopedic surgeon. And this is just a few years ago. We quickly changed that around. But so there has to be room for these things to develop. We have other areas that people can go to in terms of podiatry or other clinics that are in the larger cities. We look at this, and there's another way. For example, we don't allow any family physicians accessing our vascular laboratory at St. Paul's, and it's simply because there isn't enough time in the day to have that. And we know for a fact that most of the ones that are referred don't need to be referred, so you're getting more bang for your buck if you go through the vascular surgeon or specialist as opposed to general practice. But this is, as Dr. Lobsher was saying, in terms of prevention, this becomes a huge issue, and earlier access to better offloading it will become mandatory.
Right. I have another question that I'm sure a lot of people out there are wondering as well. Can all regions begin to use the treatment protocols now?
I see no reason why not. We've been using those protocols for years and have consistently good results. Things go much better when a plan is initiated and followed, particularly when there's a lot of staff involved. So I would certainly say yes. Because we're not actually using the primary care referral form yet, you'll need to obtain an order from the physician if you want to apply compression. So, but as far as the local wound care, there's no reason not to follow what's outlined there.
But definitely consider using the assessment form as well. Start to familiarize yourself with it. We should be looking at the etiology before we initiate treatment protocols so that we're not making a wound that should be kept dry wet. So, okay.
And I just want to say that the reason for the delay in the referral form is that we're still waiting for the SMA, Saskatchewan Medical Association, GP section to just give the final approval. And they have a meeting in end of April. So I'm hoping that there's not going to be big changes. There is a draft of the form available on the Pathway website. Excuse the spelling errors, but apparently we're told as soon as they announced the election, we weren't allowed to change anything, including a spelling error. So, but that's the principle of the form. And we're hoping by at least the middle of the year, we'll have physicians using that form. But as you all know, and I don't mind saying this, physicians, it's hard to change behavior. And so don't be surprised if you don't get that form used. And especially those of you who are attending today, you'll know way more about this than your physician or NP colleagues. So it may be up to you to be the champions for implementing some of the new tools.
And I think this next question kind of builds upon that explanation. If full implementation of the pathway is a ways away, will it be a decision of the agency or regional health authority when to start using the protocols and wound record? I guess who decides?
I think it's up to each health region. They'll be encouraged. And I'm not sure what direction will come from the Ministry of Health, because we were kind of all ready to getting to the point of rolling out, and then the election was called and we're all in hiatus. But I know the notice went out to senior leadership, I think 2 weeks ago, that the tools are on the website, that this is what the future next year we're hoping to achieve. And I'm pretty sure, you know, I think it hasn't been distributed from there down yet. But I know it certainly hasn't gone out to physicians, and we're just kind of on hold for them. But I suspect by June.
Okay.
But it will be up to each region. It's not something we can mandate.
Okay, thank you. Next question, maybe Michelle can address this one. Will NIS be using their wound care record in facilities that don't subscribe to NIS? And if not, what is the plan for standardization?
The plan for the pathway for standardization is the recommendation to use the NIS form. There is hope that each health region would perhaps subscribe to this form to use it. And I fully recognize that changing a form within a health region is a huge challenge. We implemented the NIS form in our health region when I started my position almost 9 years ago. And it took me, that was one of the first things I did, was try and get NIS in each and every facility and agency. It took me about 5 years before I got everyone on board. So it will be a challenge to change over, and the hopes is that we would use a standardized form that everyone could recognize throughout the province.
Okay. I have another question regarding wound assessment and wound measurement. Shouldn't depth be a part of the percentage calculation, resulting in a volume rather than just area?
Good question.
Yeah.
Yes, it should be. I believe we started with this just to get some sort of idea of changes in, and probably eventually we'll incorporate that into the NIS wound record. But direction from some of the literature was that monitoring that percentage in surface area, and we looked for that 50%, and that came directly from the literature, and that's why we decided to go with that at this point in time. Leg ulcers do have depth, but when we're comparing them to something like a pressure ulcer, your depth will be quite great in a pressure ulcer as compared to, say, a leg or even a foot ulcer. I mean, depending on the severity of it. So I think that's why we went with this at this point in time, but don't be surprised in the next few years to see it change as well.
Thanks, Michelle. Is there a plan to include long-term care residents in the pathway? And if so, what would that look like? For example, who would perform the lower leg assessment? Because I know we have a lot of long-term care residents in the province. Does anybody want to answer that question?
Well,
or Ken?
Here in Saskatoon, referrals for complex wounds in the long-term care setting go to the ET nurse at the home care office, and she or a designate will go and do a wound assessment and try and determine etiology and assess and plan for treatment. So certainly, you know, they should all be assessed and wounds should be treated. I think we will always have to consider the age and the comorbidities and, you know, all those factors for those persons who live in long-term care. So I guess I would say yes, just keeping those factors in consideration.
Yeah.
I think we have to think of long-term care, even though it's a fairly medicalized, nursing-centric residence, it's that individual's residence.
It's their home.
So it would be the same as me referring someone who's in their own home but requiring home care services, because wound care is going to be falling under home care, and that was a decision that was made. And so it would require a referral to your local home care for a wound assessment.
Right.
Now, who does the dressings after the assessment? It could be that the wound care nurse directs a nurse in the long-term care facility, and funding for those dressings and everything. That's something that I don't want to get into. But
Yeah, it certainly gets more complicated in long-term care because nurses are funded to look after those residents. So then the question is it that staff's responsibility to provide the care? And yes, it is that facility's responsibility to provide supplies, but that really hasn't, I mean, that's still, I think, a work in progress, and there still is some variation across the province, but it isn't, my understanding, it isn't that you can just put in a referral and home care will just come in, do the assessment, and assume all responsibility for the local wound care for long-term care residents. It is different because there is provincial funding for the care of those patients already, and the expectation isn't that the home care budget extends also to cover everything for those persons. So
but the assessment should be done.
Right, providing, well, and I mean, one of the big issues is the resources for assessment, because we struggle here in Saskatoon to have time to go and do a wound assessment in a timely manner. There's only one ET nurse in the community, and she's responsible for a whole variety of things, all the community assessments and education, and then we add long-term care. So lack of resources certainly determines what happens out there.
Okay, thank you. Another question. We are a First Nation agency and not a direct part of a health authority. How do we get the assessment form, physician follow-up, etc.?
The question is, how do we get the assessment form? So the assessment form can be found online.
Okay.
And if you Google the Sask wound pathway, you'll be able to find that quite easily. We've had extensive discussions with regards to how that flow will be on First Nations communities, and the idea, I believe, would be that they would set up their own regional wound teams in their area and do those assessments and the follow-up directly back to the primary care provider. They would be able to access the Health Canada nurses that do wound consults. I believe Donna Flair is one. I'm not sure who else is. There are two in the province. So they have access to a wound resource nurse for that follow-up if they need be. So I think they'll have that. With regards to if they're needing to access the course through Sask Polytechnic, they'll be able to access that course next year.
Okay. Sounds good. Thank you, Michelle. Regina Coppell Health Region parameters for applying moderate compression is 0.5 to 0.7. Can the wound resource nurse recommend moderate compression, or do these patients go directly to the vascular surgeon?
If the ABI is less than 0.7, they should be referred to the vascular surgeon. So they shouldn't be initiating compression until they are seen by the vascular surgeon. Anything 0.7 and above, they can initiate that compression.
Yeah, and I can comment on that. Those
Thank you.
Kind of international rules. And there are patients that have indices of 0.3 and 4, but they've seen us, and we're making the compromise. I mean, we're making that decision. But though that's quite a standard. They may and with that, I'm not sure with that question, they may have seen a vascular surgeon and they've decided that, yeah, 0.5 or 0.3 is fine in that particular patient, but those are kind of international guidelines that we're going by.
Okay, thank you. We have time for a couple more. Just let me see here. Why was it decided not to include TBI teaching along with ABPI teaching in the lower leg course, and why the decision not to train the nurses taking this course to perform these tests?
In the course, in the SAS Polytechnic course?
Yeah.
The decision was because there are a large majority of areas that don't have the equipment to start with. And secondly, the information in the literature shows that if you're not doing it very often and have competence in it, then the ability to do that without fault or error is high. And so that is why we didn't include it in the course. It was just ABI testing.
Okay. So home cares will have their own certification process and identify their own home care nurses to do that.
Yes.
Okay. Another question, could the supply formulary be sent out? Didn't see a PDF for this reference. Does anything know about that?
Well, it probably could be, but that formulary is going to change shortly a little bit. I think is it June, Michelle?
Yeah, May or
I think
June.
May or June, we're entering into a new Health Pro contract, so a few products will change. The skin sealant and barrier, and I think our alginate. So once the election is over and there's access to change, make changes on forms, that will probably happen, and we'll incorporate the new products at that time.
Okay.
So I guess for now, you can still. Is the presentation available on the website? Like this, all the individual slides? I'm not sure. They are. So I guess you could go to the website, the CEDN website, and you could find that formulary there.
Okay. When we're discussing different etiologies of wounds, would you consider compression for a trauma wound to a lower limb?
Do you want to answer that? Or you want me to? Probably. Our motto is that we should assess all lower limb wounds for compression. So if someone presents with a trauma wound and they have a large amount of edema and that wound is draining a lot, for sure, we'd want to assess them and compress that limb to reduce edema so that the wound heals faster. I think you have to look at the individual and decide, it's just dependent if edema is an important component there.
But I just want to raise from a physician point of view, so that type of wound is outside the standardized protocols.
Let's say that we have a person who has a trauma wound, but they have underlying venous disease. Okay. And the reason that wound isn't healing because they've got a large amount of edema from venous stasis, but there's been no precipitating event for a wound, because a lot of people who have venous leg ulcers are fine until they bump their leg and sustain an injury or a skin tear, and that doesn't heal and goes on to be what we see is a chronic wound. So I think there is room to consider that.
Okay.
I just might add to that too, that one of the concerns about the lower extremity clinic is we can't become the be-all. Like we're being asked to see a lot of dermatology issues, and that's what I didn't go to vascular school to learn about. But we get a lot of referrals. But the trauma actually won't so much in many cases come to our lower extremity clinic as opposed to our and our wound resource team going to the patient, because to be quite honest, majority of those are on orthopedic service and may require some different, as opposed to being referred directly to our lower extremity pathway. But that combination of the wound resource nurse or home care nurse having to go to see this and maybe in the orthopedic will be very real. Yeah, we just have to be a little bit careful about what we're willing to see, because it just will become overwhelming.
Yeah.
Yeah.
Thank you. I have another question regarding local wound care and products. So, what is the purpose of MediHoney, as it's currently being used on a non-healing venous wound? So I guess when is an appropriate time to use MediHoney? So would you use it for a non-healing wound, I guess? Arterial wound, probably.
In our practice, we don't use a lot of honey. We have on occasion for some stalled venous leg ulcers that are not responding despite, modifying everything we can. We have used honey and the silver product Acticoat combination, and sometimes seen, some different results, because changing products can have that impact. In my practice, MediHoney plays a larger role in a wound like a pressure ulcer, where we might want some debridement to occur. It is an antimicrobial, and it helps facilitate the removal of slough. What about you, Michelle?
I don't use MediHoney very much, just because typically then the nurse has to change it a lot more often, and I try and reduce the amount of times they have to change those dressings. So in instances where I have used it would be on a pressure ulcer, and I've also used it on a burn on someone that didn't have a lot of feeling in the area, because it can be painful with the osmotic effect that it has in the wound. If you have it on a wound that's not healing, I would probably ask you to review why that wound's not healing. Go back, do a reassessment, and look at the cause of the wound. Do you have the proper etiology? And maybe there's some underlying comorbidities or lifestyle issues that need to be dealt with. And maybe that's the reason, not what you're putting on the wound.
Good point, Michelle.
I can maybe add to that too,
Sure.
Rhonda, because one of the things we have to be a little careful of is product assessment. And so I know we haven't got all these standardized protocols out to everyone yet. We're doing pilot studies, and hopefully we will, but that's where a lot of time has been spent in standardizing protocols. And Michelle is absolutely right. For example, in honey is not being used at the present time in any standardized protocols that I'm aware of with lower extremity pathway clinics. Its role in pressure ulcers and burns has been well documented, but at the present time, that isn't part of it. It may become part of it, but that's where we need to go back, so we don't have honey being used over here and this being used over there. We have to make sure that we've standardized things. And just as another thing, in regard to antibiotics, for example, we're now in the process, after a year and a half, probably having to change our IV antibiotic use, or drugs that we're going to be using, as opposed to what we started with our standardized protocols. So things are ongoing and changing, and that's why we have our implementation committee and these subcommittees to keep abreast of all the new developments.